Hi everyone, this is Vicky from NP Reasoning, and today we're going to be talking about introductory concepts when it comes to diagnostic testing. Mainly, what are diagnostic tests and sensitivity and specificity? These are difficult concepts to first understand, but also apply to clinical practice. So it's super important that you have a firm grounding and understanding of these concepts as you work through cases and as you order tests. So let's get into it. As I mentioned, we're going to define what diagnostic testing is and how to apply sensitivity and specificity to clinical cases. So, again, what are diagnostic tests? You might think it's anything that you order, but in fact, it's really anything that you apply to that case to test a hypothesis, right? So, it could be any question that you ask on the history, any physical exam maneuver that you perform, lab tests that you order, imaging that you order, and a multitude of other diagnostic tests from skin biopsies, pulmonary function testing, etc. So, what diagnostic tests essentially do is they function to either increase or decrease a probability of disease. And if you need a refresher on pretest probability, you can go back and watch the pretest probability video. Diagnostic tests also help rule in or rule out various differential diagnoses that we're trying to tease through with a clinical case. And it's difficult, right? Because we want to balance over ordering things, but also under ordering things. Finding that happy medium just really it takes a lot of experience, seeing a lot of patients, but also having a firm understanding of diagnostic test principles and diagnostic reasoning in general. And as we probably know, right, tests are not perfect. We get test results that might actually not help us at all with that clinical case. So I'm going to walk you through some pearls to help you understand these test characteristics and how to apply them to that patient in front of you. So, as we know, there are four outcomes of a test, right? There's no possibility of a perfect test out there. We do have our gold standards, but there's always the possibility of these four outcomes. Either we're ordering a test for a disease and it comes back positive, and that person has the disease. That would be the true positive. Or we're ordering a test for a disease and it comes back as positive, but in fact, that person's healthy. They don't have the disease. Third, we may have a false negative result. So we're ordering a test for a disease and it comes back as negative, but in fact, it's missing that person's disease. So it's a false negative. And then fourth, there's the true negative, right? We're ordering a test to help rule out a disease or assess for a disease, comes back as negative, and in fact, in reality, that person is free of disease. So we need to, understand that there are limitations for any test that we order in clinical medicine, and we need to make sure that we're correlating that test result to the case. So don't always take that test result at face value. Before getting into sensitivity and specificity, I do want to recap pretest probability. So again, that is the likelihood a patient has a disease before any diagnostic test is performed. So any test that we add to this case is going to help move the needle on our pretest probability. It's either going to lower our pretest probability and help rule that disease out, or it's going to increase our pretest probability to help rule that disease in. So before ordering any more tests, I always will ask these questions. What's the probability of X disease? If it's in that intermediate range, that's a good indicator that you need to do more testing. Two, have I reached the treatment threshold? If I have reached the treatment threshold, I'm firm on my diagnosis, I'm ready to treat, I probably don't need to order any more tests, right? Third, will any test change my plan for management? If the answer is no, you can probably pause there and go ahead and manage your patient. Fourth, could ordering a test do more harm than good? You always have to weigh the risk benefit of, getting a false positive result, getting a false negative result, and causing anxiety and diagnostic uncertainty. And then fifth, introducing this question is before ordering a test, what I always like to ask myself is if this test comes back negative, what does this mean for my case? Is it going to help? Or what about a positive result? Am I going to trust that positive result? Is the test good enough for that? Could I Is it going to help, this clinical case? So these 5 questions, if you're ever uncertain about what to order or whether you should order something, this will help guide you through. So, what is sensitivity? Each test that we order has a specific sensitivity and specificity. These numbers are generated from research studies, right? So, it's important for you to have a general idea of a test's sensitivity and specificity for that particular condition before ordering that test. So, sensitivity is the ability of a test to correctly identify a patient who truly has the disease. In other words, all patient with the disease are correctly identified as having the disease with a high sensitivity. So a flip way to think about this is a test with high sensitivity gives you a low risk of false negative results. So you can trust that result. However, a test with low sensitivity, there could be a high risk for false negative results. So you have to be careful if a test has a low sensitivity. Good acronym to remember is a highly sensitive test will help rule out a disease. So SNOUT rules it out. And I'll provide some examples in a minute. Specificity, on the flip side, is the ability of a test to correctly identify a patient as being disease-free, so without disease. So a test that's highly specific will identify all healthy patients as being correctly identified as healthy. So, a flip way to think about it again is a test with high specificity. You're going to have a low risk of false positive results. However, a test with low specificity, there's a high risk of false positive results, which could send you down a path of ordering many more tests. Acronym to remember here is, a test with high specificity will help rule it in. So SPIN rules it in. Now, to make sense of this mumbo jumbo, let's get into some clinical examples. So, let's say a patient's presenting to you with a malar rash, fatigue, and joint swelling. Right away, if you're familiar with a lupus presentation, I'm worried about lupus. So, for me, even with these points alone, the probability of lupus or another rheumatologic disease is at least an intermediate pretest probability. So, I haven't landed the diagnosis, of course. I haven't reached the treatment threshold. Will any test change my management plan? Yes, I need to screen for rheumatologic disease because this patient might need treatment. And could ordering a test do more harm than good? Probably not more harm in this case, but there's always a risk of a false positive result with certain rheumatologic markers. So there's a risk. So let's think about ANA testing, right? This is a common blood test that's used to screen for autoimmune disease or rheumatologic disease, but it's not specific to lupus, right? In other words, it has a high sensitivity. So ANA is very good at detecting people with true lupus. So there's a low risk of a false negative result. You're unlikely to miss lupus with a positive ANA. However, it has a low specificity, meaning it's not good at identifying patients without lupus. So there is a high risk of a false positive result. There's a certain percentage of the population that will have a positive ANA on labs and not have any type of rheumatologic disease. So keeping that in mind, when I'm ordering this test, if it's positive, chances are, it could be a false positive, but it definitely makes sense with that presentation. Um, and if it's negative, then I have a pretty reasonable confidence that it's ruled lupus out, right? Let's say here the result is ANA positive at a titer of 1 in 160, which is pretty high. So right away I'm going to send off a rheumatologic referral. So again, ANA has a high sensitivity. It's good at detecting people with lupus, but has a low specificity, which means there's a high risk of a false positive result. So you have to be careful in ordering this test for the correct clinical scenario like the one provided. Example 2, a patient presents with a chronic cough and unintentional weight loss. So right away, that's concerning, right? I'm thinking about a possible tuberculosis, malignancy, thinking about lung cancer or a type of malignancy. My probability right now is intermediate. Chronic cough, unintentional weight loss, Don't love that. Have I reached the treatment threshold? With the history and physical exam alone, I haven't. Would any test change my plan for management? Absolutely. For example, a chest x ray screening for malignancy. And at this point, the benefits outweigh the risk of ordering that diagnostic imaging, right? Thinking about chest x ray test characteristics for detecting lung malignancy. So, a chest x ray for lung cancer and detecting, it has a high specificity, meaning if a mass is seen on imaging, it's likely real. So, there's a low risk of false positive results, especially when you correlate it to that patient in front of you. However, chest x ray has a low sensitivity. If it's a clear chest x ray, it could miss lung cancer, meaning there's a risk of a false negative result with this picture. Third example, let's say a patient presents with dysuria and point of care urinalysis shows positivity for nitrites. There's no complicating factors with this UTI presentation. So for me, there's dysuria, positive nitrites on the urinalysis. Those are pretty high pretest probability for an uncomplicated UTI at this point. Treatment thresholds probably reached. And would any test change my management plan? So urine culture sensitivity, urinalysis. Unlikely, because if it's an uncomplicated UTI, I know which antibiotics to use. And could ordering a test do more harm than good? I mean, possibly, especially if you're waiting for those test results to come in. So, thinking about the nitrite test specifically on urinalysis, we need to know the sensitivity and the specificity, right? So, sensitivity for nitrites is actually low, meaning if you get negative nitrites on a urine dip, it could be a false negative. It doesn't rule out a UTI because many bacteria don't produce nitrites, but that can still contribute to a UTI presentation. However, nitrites do have a high specificity on urinalysis. So if you get a positive result for nitrites, it's likely a true positive, and that is a strong indicator of a UTI, meaning you probably don't need to order any more tests for that. So, as you can see, there's a lot to kind of understand and integrate when it comes to test characteristics. For sensitivity and specificity, the best way to digest this information is just applying these test characteristics to cases that you see and to tests that you're going to order. I'm not going to go through this whole table, but you can pause and review, and anytime you need to go back to it when you're ordering a test, this could be helpful for you to use. Key take home points, again, going back to these main questions you're going to ask yourself before ordering any tests. What's the probability of disease? Have I reached that treatment threshold? Will any test change my plan for management? Could ordering a test do more harm than good? What will I do with a negative test result? And what about a positive test result? So, what is the sensitivity and specificity of this test for this disease? Can I interpret them with confidence, or should I be interpreting them with caution? Thanks so much. I hope that was helpful. I'm going to get a video out on positive and negative predictive values, which I find even more helpful to applying to clinical cases. Again, you can check out all of this written content on the NP Reasoning Education blog. Thank you so much for listening today, folks. Bye-bye.